So we're going to talk about ventilator waveforms and basically what to expect or be prepared for on the RT board exam. And so let's just review real quick what the basic ventilator waveforms should look like in a normal patient. And we can start with flow. If we have a square flow pattern and the patient, let's say the flow is set at 50, as the breath begins to be delivered, the flow is going to immediately begin or be delivered at a constant flow rate of whatever you have set. So it's going to immediately go to 50. It's going to go over sideways like this until the tidal volume is reached if you're in volume control. And then it's going to immediately cycle off and air is going to exit the lungs, and this will be negative flow that comes out of the lungs back to a baseline of 0. Okay, so the pressure waveform is going to look like this. If you have the PEEP set at 5, it's always going to start wherever the PEEP is set. So in this case, we'll say the PEEP set at 5, and the pressure is just going to increase as the breath is delivered. And as soon as it reaches that tidal volume, it's going to just decrease back to whatever the PEEP is set at, and it's going to carry on like that. Okay? The volume in a normal patient will begin at 0 as well, and it will increase to whatever the tidal volume is set at. Let's say it's set at 500 again. Then it's going to cycle off and return back down to 0. Okay? So these are an example of just what these waveforms should look like in a normal patient. Okay? And so for the board exam, let's talk about what we might see or need to be prepared for. And there's something called flow starvation. And in that case, that's when the patient wants more flow than what we have set. So what that's going to look like in a square flow pattern is the breath will be delivered, but you'll get this scoop right here, okay? And that scoop represents the patient breathing in hard at a higher flow rate than what is set. And so that can make them uncomfortable. They can begin to become asynchronous with the ventilator and breathe against it. And we want our patients to be comfortable. So in this scenario, when we see that kind of scoop right here, we want to give them more flow. So that would be a sign to increase the flow rate. Okay? We also want to be able to identify time-triggered breaths that are delivered from the machine based on whatever the respiratory rate is set at versus patient-triggered breaths. So this first pressure waveform is a time-triggered breath delivered from the machine. If the patient decided to take a breath in assist control mode and get a full tidal volume, what we would see is a negative deflection in the pressure waveform, and then the breath would be delivered, the pressure would increase just like it always, and then return back to the PEEP setting. Okay, so here we have a patient or a machine triggered breath, and here we have a patient triggered breath with this negative pressure deflection that represents when the patient tried to generate a breath. They generated negative pressure, and that's what triggered the breath. Okay, so another thing we can identify for the board exam that you may see is secretions in the airway. And what that's going to look like on the pressure waveform is you're going to see like this jaggedness. Kind of looks like Bart Simpson's hair. All right. And what that is airflow is oscillating as it passes through the secretions in the airway. The air oscillates, and you're going to get these differences in pressure. Okay. So if you see that kind of Bart Simpson looking hairdo like that, that's going to be a sign to suction your patient. Okay? So what else can we see? Well, let's say the patient has a chest tube, or perhaps their endotracheal tube cuff is not inflated enough to seal off their airway. We're going to see a leak, and what that's going to look like we're going to see that on the volume waveform. As the breath is delivered, it reaches the set tidal volume, but as it comes down, it just kind of flattens out and never returns back to the 0 level. Okay, so that is a example of a leak. All right. Okay, so let's be able to identify that, and Let's look at another scenario that you may encounter, and that's the classic COPD patient where they get a breath from the machine, the flow increases, it's delivered just as always, but as they exhale, it takes forever for that flow to get out of to make it back to zero and get out of the patient's lungs, and sometimes it doesn't even make it to zero, okay, before the next breath is given, right? And that causes air trapping, and that can also cause asynchrony with the ventilator, and it can become a big problem. So we want to be able to identify it and treat it, and this is how we kind of identify this prolonged expiratory phase. It really takes forever to get the air out of the patient's lungs, and to treat it we would obviously recommend bronchodilators as a treatment for that. Okay, so you're also going to see in COPD patients it's going to take a long time. If it takes a long time for the flow to come out, well, it's going to take a long time for the volume to come out. Let's start back at zero for this breath. Okay, so the breath will be delivered, it'll make it to 500, but it'll just take really long to get back down to zero. Okay, it may eventually get there, but it takes a long time.